So over the next 15 minutes, I would like to start with a description of some historic data on the natural evolution of systemic juvenile idiopathic arthritis, and then discuss some of the new trends that we have observed over the last 10, 15 years. Now, as you probably know, systemic juvenile idiopathic arthritis represents approximately 10–15% of the total population of patients with juvenile arthritis, with a broad peak for disease onset somewhere between 1 and 5 years of age. But it may occur at any age. And if a patient is older than 16 years at disease onset, we typically call this disease as adult onset Still's disease. Now, we use arthritis in the name of this disease. However, at disease onset, the arthritic component of systemic JIA is usually completely overshadowed by the systemic features. And in fact, in about 10–15% of the patients, we may not see arthritis at all during the first months of the disease. And these systemic features are shown here. The most classic features, spiking fevers. If you look at this particular panel here, you see 2 fever spikes per day. Some patients have 1 fever spike per day. These fever spikes typically occur at the same time of the day. And in between the fever spikes, the temperature usually returns back to the normal range, or occasionally even goes below the normal range. These patients almost always develop a very characteristic rash, which is shown in this particular example. In the majority of these patients, the rash typically shows up only with fevers, but it may be persistent and may be still present even in between the fever spikes. Another very characteristic feature of systemic juvenile idiopathic arthritis is significant lymphadenopathy. So in this particular kid, we are looking at markedly enlarged lymph nodes in the armpits, in the neck area. And also, if you look at her, you see this protuberant abdomen. This is because of markedly enlarged liver and spleen. So hepatosplenomegaly, a very characteristic feature. In many of these kids, we also see significant inflammatory activity in what we call serosal linings, the linings that surround the lungs and the heart. And in this example, in this X-ray, we are looking at a massive pericardial effusion. So there is quite a bit of fluid around the heart of this particular patient. Now, in general, over time, these systemic features tend to resolve in the vast majority of the patients. And in fact, what happens long-term to these kids mainly depends on whether this massive systemic inflammatory response that look like sepsis to us, whether it settles down in the joints. And if it happens, then these patients develop very severe, very destructive arthritis. And it happens in approximately 50–60% of the patients. If it happens, we may see some destructive changes in the joints as early as by the end of the 2nd year of the disease. In about 50% of these patients, we see very impressive hip involvement. And if it happens, about 1/3 of those patients would need a total hip replacement surgery before they become adults. And another strange and sort of perplexing feature of systemic juvenile idiopathic arthritis is a rather high prevalence of what we call bony ankylosis, when bones fuse and the patients lose the ability to move their joints. And that usually happens in the neck, but also in the wrists and feet. And in this particular example, we are looking at the fusion of the bones in the neck. And again, it's rather characteristic for systemic juvenile idiopathic arthritis. Here, we are looking at a relatively early destructive changes in the knees. So in this example, what we would like to see, we would like to see a nice space between the bones, and this space is filled with healthy cartilage. And as you can see, in particular patient, this space is narrowed. It means that the cartilage is lost. And it's there is some kind of remodeling that the bone is trying to repair itself. So we see this sort of bizarre appearance of the joint space. But also, if you look in this area, we start seeing erosions in the bone itself. So these are significant destructive changes that certainly are going to limit the ability to move the joints and the quality of life of this patient significantly. These are three different studies that were performed mainly in the 90s. They're coming from three different geographic areas. The first study is coming from the States. This one is from Canada, and the third study is from Southern Europe. And again, all these studies show that about 30–40% of these patients develop destructive changes in the joints by the end of the second year of the disease. I would like to briefly mention a couple of other serious complications of systemic juvenile arthritis. Certainly, we're very worried about growth of these kids. In this example, we are looking actually at two twin sisters. Believe it or not, they're twins, but the disease affected the growth of this patient in such a profound way that you would never guess this. And another serious complication that we are all of us very afraid of is called macrophage activation syndrome. This particular complication is viewed as a cytokine storm. Just to sort of explain what cytokines are, in this figure we are looking at immune cells, various immune cells, and these cells typically communicate with each other by sending something that I would describe as chemical signals. And these molecules, these chemical signals are called cytokines. Some of them stimulate immune cells and they're pro-inflammatory, some may be actually anti-inflammatory. So in macrophage activation syndrome, we see excessive activation and multiplication of predominantly two types of immune cells, T lymphocytes and macrophages. And these cells produce massive escalating amounts of those pro-inflammatory cytokines. They kind of stimulate each other. That leads to this sort of development of a vicious cycle, an overwhelming inflammatory reaction that may be life-threatening. So in this example, we are looking at a normal, healthy macrophage. In normal conditions, what these cells do, they typically phagocytose, they engulf and destroy microbes. That's their normal function. That's sort of what they do to protect us against microbes. In macrophage activation syndrome, the cells become overly activated. And again, they start to secrete massive amount of those pro-inflammatory cytokines. In addition, they start phagocytosing, engulfing and destroying normal blood cells, such as red blood cells, neutrophils, and platelets. And the destruction of these blood cells may lead to a sudden drop in their numbers, and that potentially could be life-threatening. And this is an example. It's one of my patients that's a bone marrow aspiration. And again, what we're looking here, you see that this large cell in the center, these are macrophages. And what they do, they engulf other healthy looking blood cells in the bone marrow. In this example, we're looking at a neutrophil. Here it's probably an immature red blood cell. And the engulfment eventually leads to a complete destruction of those cells. In this example, we're looking at the remnants of those cells. Now, the established treatments of macrophage activation syndrome include high-dose corticosteroids. We often use cyclosporine. Sirolimus would be another medication that is becoming a bit more popular than cyclosporine. Certainly, some patients would benefit with anakinra, a drug that blocks one of those cytokines called IL-1. And in more difficult cases, we may use etoposide. Now, there are several new treatments that are under investigation right now. So the first one that I would like to mention is Gamifant. It's a biologics that neutralize interferon gamma. That's one of those cytokines that we believe is most critical in macrophage activation syndrome. And the preliminary results of the ongoing clinical trial, in fact, look very, very promising. Another potential drug is the biologic that blocks IL-18. And again, this will be discussed later tomorrow and the day after tomorrow in our meeting. And another sort of interesting area of investigations right now is the potential role of JAK-STAT inhibitors, including tofacitinib, baricitinib, and ruxolitinib. Now, that's about the macrophage activation syndrome. What about the systemic juvenile idiopathic arthritis in general? Here, I would like you to sort of take a broad look at the history of the treatment of juvenile idiopathic arthritis. We started in the late 80s with non-steroidal medication, non-steroidal anti-inflammatory medications, corticosteroids, Methotrexate was introduced in 1991. And then sort of really what made a huge difference for patients with non-systemic juvenile idiopathic arthritis is the introduction of the drugs that block TNF. So that's another pro-inflammatory cytokine that seems to be prominent in non-systemic JIA. That change, the introduction of those drugs, had a dramatic impact on the quality of life of patients with non-systemic JIA, but it had little help for patients with systemic JIA. And in the early 2000s, we actually learned that the development of systemic JIA may be associated with a spontaneous activation of innate immune cells producing two other pro-inflammatory cytokines, IL-1 and IL-6. And in fact, if you think about the biology of these two cytokines, most of the clinical and laboratory features of systemic JIA, in fact, could be directly attributed to the effects of the two cytokines. And again, sort of, I'm showing you here. So it looks like the immune cells in systemic JIA communicate with each other through sending those two cytokines, IL-1 beta and IL-6. And these observations eventually led to several large international clinical trials of drugs that block either IL-1 or IL-6. The results of those clinical trials were published in December 2012 in the New England Journal of Medicine, and that quickly led to the approval of these drugs by the FDA for systemic juvenile idiopathic arthritis. Just a very, very brief summary of the results of these two trials. So if on the left side, you look at tocilizumab, a drug that blocks IL-6. On the right side, you look at canakinumab, the drug that blocks IL-1 beta. The outcome, ACR 90, sort of roughly it means that we have 90% improvement in the clinical features of systemic juvenile idiopathic arthritis. It was observed in almost 2/3 of patients. In fact, during the early stages of the treatment, about 30% of the patients developed a complete remission. We observed a complete resolution of arthritis in about 50% of these patients, and about half of the patients were able to completely stop corticosteroids. So this was a very, very important achievement, and as a result of this, in the vast majority of the patients, I would say about 75–80% of the patients, we now should be able to control the disease relatively well and certainly prevent this kind of complications that I described earlier. So certainly we do believe that IL-1 and IL-6, these two cytokines are the major players in the vast majority of patients with this disease. In some patients, it's predominantly IL-1, and these patients would respond to only IL-1 inhibiting agents, but not tocilizumab. In some patients, it looks like both cytokines play a role, and we can block either one of them, and the patients will improve. Then there is a subgroup of patients where we believe the IL-1 does not play a role at all, but IL-6 does. And these patients typically respond to tocilizumab, but not to canakinumab or rilonacept. And then unfortunately, there is about 20% of the patients who do not show any response to either of these treatment strategies. And again, it's a substantial proportion of patients. And again, sort of right now, that's the area of very, very intense research where we're trying to understand what other therapeutic targets might be considered. We certainly think about the possibility of targeting IL-18, and there are a couple of clinical trials in preparation. But as you heard earlier this morning, there is increasing interest in JAK inhibitors in this patient population. So the advantage of JAK inhibitors is that unlike the biologics that we just discussed earlier that typically target just one particular cytokine, JAK inhibitors may control signaling pathways induced by several cytokines, and it may be advantageous in some of the patients. Another concerning thing that we've learned over the last few years is that unfortunately, even in those patients where canakinumab and tocilizumab work very, very well and control the disease in a very effective manner, these patients still may develop macrophage activation syndrome. And in fact, sort of our estimate that the overall incidence of MAS, the rate of MAS, its severity and mortality essentially do not appear to be modified by the treatment. And then this—
One more minute.
Yes, and this very, very disturbing paper that was published by Yuki Kimura in 2013, she described 25 patients with this peculiar lung disease that seemed to be relatively new, that we did not see before. And again, this is certainly true in our center as well. Over the last 5 years, of the approximately 75, 85 local systemic JIA patients, 6 developed this particular lung complications, and we suspect that the prevalence of this complication may be as high as 6–7%. And again, this will be the topic of our discussions today, tomorrow, and on Friday. Rashmi, that's my last slide. So if we have time and we have questions.
I'll ask one question that came up. Somebody asked, does methotrexate really help? And they've been giving it for 2 years, but they can't really tell if it has any impact.
So my feeling, my personal opinion is that it does very little for the systemic component of the disease. But there is a small population of kids who develop this persistent arthritis without much evidence of systemic disease, and those certainly may respond to methotrexate. If you look at the original clinical trial of methotrexate that was performed in 1991, the patients enrolled at that study had polyarticular course of the disease. About 12 of them had systemic onset, and they actually showed some response to methotrexate similar to the other subtypes of JIA. So yes, there is a proportion of patients with persistent arthritis that may respond to methotrexate, but I'm skeptical about using methotrexate for the systemic features of the disease.
Got it. And do you see GI issues coming up with SJIA? As you can see, several of even like the patients earlier reported. Do you see it in your own practice? IBD, etc.
So certainly, I remember seeing a couple of patients like that, and in fact, we were wondering whether we kind of made a mistake with the initial diagnosis. However, I think Betsy Mellons, Dr. Mellons, are you on this call? Dr. Mellons recently published an interesting paper describing a small cohort of patients that seem to have both systemic juvenile idiopathic arthritis and inflammatory bowel disease. And I believe it was about half a dozen of patients from the CARRA cohort. Is Dr. Mellons on? I saw her name somewhere.
Yeah, Michael Umbrella is saying that he saw several of those at the NIH. Michael, do you want to speak up?
Not really much to say other than the fact that indeed there seems to be a cohort of people who have overlap of inflammatory bowel disease-like symptoms together with systemic JIA features, arthritis and systemic features. It's confounding because inflammatory bowel disease, especially with early onset, can have a febrile debut, as many of the autoimmune diseases can. So as Dr. Grom alludes to, there can be an issue of mischaracterization or misrecognition of IBD with a febrile debut as systemic JIA. And given the presence of arthritis in the subset of patients with IBD, it can continue to look like systemic JIA over time.